morning, everyone. Am I audible?
Yeah.
Yes.
Are my slides visible?
Yes.
Thank you very much. First of all, I would like to thank the Endocrine Society of India for giving me this opportunity. Just a minute. Yeah. First of all, I would like to thank Endocrine Society of India for giving me this opportunity to deliver a talk on this topic of HIV and endocrinology. This is the data regarding the epidemic of HIV till 2019. There are around 38 million people living with HIV till 2019, with 1.7 million people newly diagnosed HIV till 2019, and with 6,90,000 death due to HIV. If you see the global HIV incidence and prevalence, since the availability of highly active antiretroviral viral therapy in the mid 90s, we could see there is gradual decrease in the incidence of HIV infection, and the new HIV infection has reduced by almost 40% since its peak in the 1998, and the mortality has also reduced since almost 60% since 2004. And the global availability of ART has significantly increased. Same is the situation with India. There is reduced incidence, and the prevalence has almost flattened thanks to the availability of highly active antiretroviral therapy. But the availability of antiretroviral therapy has caused the HIV to change from a disease with acute infection and high mortality to a chronic disease with its metabolic complications. So endocrine gland involvement in HIV could be because of infiltration of the affected gland by infection or malignancy, or it could be due to the immune activation with pro-inflammatory cytokines, and it could be because of the drugs. So as you can see, because of the various endocrinopathy, because of HIV infection, it can involve adrenal, it can involve the pituitary, the gonadal axis, growth hormone axis. Also, there could be destruction of the endocrine gland by HIV by the infection. There could be hemorrhage or abscess in the affected gland. There could be endocrinopathy because of the drugs which are commonly used in the HIV for the treatment of HIV. So we will see the various glands which are involved by HIV infection. We first see the adrenal gland. So the adrenal hypothalamic-pituitary-adrenal axis is the most frequently involved abnormality. It is a spectrum. It could range from the adrenal insufficiency at the one end with elevated cortisol level, which is more frequent at the other end. Adrenal insufficiency, this was the study which was conducted in Africa, where there is high prevalence of HIV infection. They have seen that HIV, the adrenal insufficiency could range from 27.5 to 34.5%. Indian studies, they have shown that the adrenal insufficiency could be present in 24 to 74% of the HIV infected individual, and it could be subclinical or frank adrenal insufficiency. The causes could be HIV infection, opportunistic infection, CMV adrenalitis, which was seen in 93% at autopsy studies. Apart from that, malignant infiltration, hemorrhage, necrosis at the level of pituitary or adrenal may be the cause, or by medications. But the adrenal involvement, adrenal insufficiency usually manifests when there is more than 80 to 90% of adrenal gland involved, destroyed by the opportunistic infection. Now, coming to the hypercortisolism, it is more common in HIV infection as compared to adrenal insufficiency. There is increased basal ACTH and cortisol level in considerable number of HIV infected patients, and there is blunted ACTH and cortisol response to stress and CRS stimulation. The cause could be due to the shift of the steroidogenesis from DHEA and aldosterone to cortisol, and stimulation of hypothalamus-pituitary-adrenal axis by the cytokines. Other causes could be the stimulation, the interleukin 1 and TNF alpha, which provoke the overexpression of 11 beta HSG1, which lead to the transformation of inactive cortisol to active cortisol. This was the another study. There are there are multiple case reports where they have seen that HIV infected patient with clinical symptoms of cortisol excess, which usually suppressed with standard dexamethasone suppression test. And most of these patients were on antiretroviral therapy, that is protease inhibitors. Now, if you see the drugs which are which induce cortisol dysfunction, there are various drugs like antifungal ketoconazole, which blocks the multiple steps in the adrenal steroid biosynthesis pathway. Then we have rifampicin, which accelerate the metabolism of cortisol via its inducing effect on the cytochrome enzyme. Then we have phenytoin, which increases the steroid clearance. Magistral acetate, which is used for the anorexia and muscle wasting. It has intrinsic glucocorticoid axis and can suppress the HPA axis. Now, coming to the symptoms, the classical symptom of adrenal insufficiency may not be manifested in each and every cases, and many clinical features, they overlap with those of the HIV infected individual. Patient can present with unexplained fatigue, hypotension, anorexia, weight loss, and fever. Abnormalities like hyponatremia, hyperkalemia, or hypoglycemia could be there. If we do imaging studies, the adrenal could be even normal, large, or small. Large adrenal can be seen in early cases of tuberculosis, but they may become progressively small and fibrotic. Calcification could be there. And in case of fungal disease, we can see the large adrenals. Apart from cortisol excess, mineral corticoid excess is also involved, but it is rare. Hyperkalemia and hyponatremia are commonly observed in AIDS patients, and some of the mortality could be because of the mineral corticoid deficiency. Hypocortisolism has been described in HIV infected patient with advanced illness, and there are few case reports of primary hyperaldosteronism. It is mainly because of the renin-like activity of HIV aspartic protease, which would lead to the aldosterone hypersecretion. Now, coming to the hypothalamic-pituitary-gonadal axis, the Indian studies have reported a prevalence ranging from 13 to 33% in patients with HIV, and it is commonly found in male patients with secondary hypogonadism. Was the most common cause of hypogonadism, accounting around 66% of the patients, and it is significantly associated with the age, CD4 count, and the duration of ART. The etiology of hypogonadism is multifactorial, and secondary hypogonadism might be due to severe illness and involvement of opportunistic infection or malignancies. Primary gonadal failure, it is due to opportunistic infection or infiltration by the neoplasm like Kaposi sarcoma, and various cytokines leads to decrease in the Leydig cell steroidogenesis. Now we'll see if you see the pathogenesis of hypogonadism, there are various factors like HIV related lipodystrophy associated with metabolic syndrome. Opportunistic infection can lead to the hypogonadotropic hypogonadism, or multiple opportunistic infection involving the testes, and HIV per se can involve the testes. The heart associated complication and the inflammation can lead to involvement of testes, leading to the hypergonadotropic hypogonadism. The signs and symptoms do not differ between the HIV infected and the HIV infected individual, and the severity mainly depends upon the symptoms and signs depend upon the severity of hypogonadism and individual susceptibility. Patient can present with hot flushes, decreased sexual function like sexual desire, sexual activity, sleep related erection. There could be reduction in the testicular volume followed by reduced secondary sexual characteristics. Now coming to the diagnosis, the Endocrine Society recommend the total testosterone less than 300 nanogram per deciliter to samples for the diagnosis of hypogonadism. There are also HIV Medicine Association of Infectious Disease guideline, which recommend a morning free testosterone. Now this is the algorithm for the diagnosis of hypogonadism. In HIV infected men, we after measuring total testosterone and LH, if it is more than 300 and LH is increased, we call it as a compensated hypogonadism, and if it is less than 300, it is a biochemical hypogonadism. We will proceed with if we have increased LH, it will suggest you of hypergonadotropic hypogonadism. In case of if we are suspecting there is altered SHBG level, we can measure the SHBG and free testosterone also. If the free testosterone is less than 50, we can go for LH, and if LH is increased, it is hypergonadotropic hypogonadism. In HIV infected individual with HCV or HBV co-infection, because of altered SHBG, we have to measure SHBG simultaneously. And similarly, we can proceed and we can diagnose the hypogonadism. Now, coming to the thyroid function, subtle thyroid dysfunction, it occurs in around 35% of HIV infected individuals. And in contrast, the overt hypothyroidism is less common, around 1 to 2% of all patients. And many factors could be implicated in the pathogenesis. Firstly, HIV itself, followed by several opportunistic infection, drugs, and immune reconstitution syndrome. Now, hypothyroidism, the subclinical hypothyroidism is higher as compared to the general population, but the overt hypothyroidism, it is around reported 0 to 2.6% of the patient, and it is mainly non-autoimmune, as in general population it is autoimmune origin. There are various drugs like used in the for treatment of various complications and the tuberculosis. They can have effect and can lead to hypothyroidism. Now, coming to the non-thyroidal illness, the occurrence of 6U thyroid among HIV patient, it varies from 1.3 to 11.6%. It is characterized by low or normal T4 level, low T3 level, and elevated RT3. The prior use of ART and non-thyroidal illness are common feature in AIDS patient, and the frequency as high as 16% are found in terminally ill AIDS patient. And management involve the treatment of the underlying condition, not to administer levothyroxine therapy in these patients. Now, coming to the hyperthyroidism, the induction of immune restoration by heart has been linked to the thyroid dysfunction in some studies, and primarily occurrence of Graves' disease. It has been reported after 12 to 36 months after institution of ART, and it has been found in approximately 2% of patients after introduction of antiretroviral therapy. Also, the interferon, which is used for the treatment of hepatitis C, has also been associated with development of Graves' disease, but subclinical hyperthyroidism is rare in patients with HIV infection. Now, coming to the thyroid, it is various systemic opportunistic infection can infect or infiltrate the thyroid, like pneumocystis infection, cryptococcal neoformans, and suppurative bacterial infection. And these infections lead to destruction of the thyroid, which is usually accompanied by neck pain, thyroid enlargement, and increased thyroxine release. Thyroid function, it usually return to normal after the treatment. Various malignancies like lymphoma, Kaposi sarcomas can also infiltrate the thyroid and impair the function. After the availability of active retroviral therapy, the symptomatic thyroid infection has significantly reduced and is now rare. Now, coming to the interesting topic of diabetes mellitus, there could be three possibilities, like patient with pre-existing diabetes who contact HIV, and those who are diagnosed to have diabetes at the onset of HIV infection, and those who develop hyperglycemia after the start of the therapy. Previous various studies have found that the incidence could be around 14% in people living with AIDS, which is 4 times higher than that among the HIV seronegative control. Indian studies have found that the prevalence is 2.1% of diabetes, and in the same study, they have found the percent of the patient developing metabolic syndrome was around 19% according to IDF criteria and 25% according to ATP3 criteria. And diabetes mellitus found to be 3 times more prevalent among patients receiving ART. The proposed mechanism is insulin resistance, lipodystrophy, and mitochondrial dysfunction. And also, the patient with HIV and HCV co-infection, they have 3 times more likely to develop diabetes than those of same age match control without HIV, HCV infections. This is the another study by India where they have found the metabolic syndrome was 14% and 18% by different criteria, and half of the patient they had either exhibited at least two or more features of metabolic syndrome. And metabolic syndrome was more common in those who are receiving protease inhibitors, and type 2 diabetes prevalence was 5 to 9-fold higher in those with metabolic syndrome patients. Now, coming to the impact of drugs which are used in the treatment of HIV on the pathogenesis of diabetes mellitus, various drugs, they lead to the alteration in the glucose homeostasis, like protease inhibitor, as I told previously, indinavir and ritonavir, they block the insulin-mediated glucose disposal by directly blocking the GLUT4 receptor. Then there are various drugs like they suppress the hepatic glucose. They increase the hepatic glucose production and release. Indinavir and insulin loses some of its ability to suppress hepatic glucose production, and glycogenolysis and gluconeogenesis increases. Then we have nucleoside reverse transcriptase inhibitor. Previously, it was believed that the nucleoside reverse transcriptase inhibitor, they have no role in the alteration of glucose homeostasis. But later on, it was found that stavudine and various other drugs, they also lead to the alteration in glucose metabolism. And these drugs, they also associated with increase in the lactate level. So we should be cautious while using these drugs along with the metformin. Then there are other drugs like pentamidine, which are used for the this pneumocystis infection. It is associated with beta cell toxicity and commonly lead to hypoglycemia. Then we have this magistral acetate, which is, it has intrinsic glucocorticoid activity and can lead to alteration in the glucose homeostasis. Now, how will we screen the patient for diabetes? The USA panel, they recommend fasting plasma glucose as the test for choice for the screening of these patients, while the South Asian consensus guideline recommend both fasting and the postprandial glucose value for screening and during the monitoring of therapy. And we should use venous sample. And HbA1c is not accurate assessment of glycemic control because of the altered RBC lifespan in these patients. Now, coming to the pancreatic dysfunction, pancreas is frequently a target organ of opportunistic infection like mycobacteria and the cytomegalovirus and various malignancies. And autopsy studies have found that HIV infection patient, they have almost found as many as 90% of the patient, they have pancreas involvement. Pancreas is commonly, pancreatitis is also seen as as effect of drugs, various drugs which are used for HIV infection, and like pentamidine, trimethoprim, diadenosine. And there could be hypoglycemia as a result of inflammation of islet cells leading to insulin release. Pancreatic exocrine insufficiency is an important non-infectious cause of diarrhea and fat malabsorption in HIV patient. Now, coming to the fluid and electrolyte imbalance, hyponatremia is the most common electrolyte disorder with patient with AIDS, and various studies have found that the hyponatremia range from 23 to 75% of these patients, commonly in the AIDS patient. And it was commonly because of volume depletion secondary to the multi-organ involvement, and other causes could be SIADH or adrenal cortical insufficiency or hypoaldosteronism. Now, apart from hyponatremia, hyperkalemia is also common, which is found in 5 to 53% of AIDS patients, and it is commonly because of insult to the kidney, adrenal gland, pancreas in association with AIDS or its therapy. Trimethoprim, which is commonly used for the treatment of pneumocystis, it has intrinsic, it can block the apical membrane sodium channel in the distal nephron, similar to AIDS and similar to amilorides, and can lead to hyperkalemia. Apart from that, adrenal insufficiency from several causes can also lead to hyperkalemia, and various chemotherapy which is used for treatment of AIDS-related malignancy can also lead to tumor lysis syndrome and hyperkalemia. Now, coming to the growth hormone axis, the initial studies which were conducted to evaluate the growth hormone, they were conflicting results were there. The initial studies, they have shown no abnormality when this study was conducted in 1996, where they have they frequently sample the growth hormone, and they found that there was no abnormality. Now, afterward, the subsequent studies, they have found that there was conflicting result with higher serum GH and lower IGF-1, suggesting a condition of GH resistance. So the difference between these two studies was that the initial studies, there was no wasting, and in the subsequent studies, the most of the individual, they had wasting, and which leads to this condition like resistance to GH action. So later on, the availability of antiretroviral therapy, the number of patients developing metabolic complication out of antiretroviral therapy like lipodystrophy and other metabolic syndromes, they have increased, and the investigators, they have renewed interest in the growth hormone deficiency as a cause of this lipodystrophy syndrome. And the first pilot study, which was conducted in 2001, it shows that the growth hormone secretion is impaired in patients with HIV infection, and especially those with lipodystrophy. They have used this GHRH arginine test to diagnose growth hormone deficiency with peak GH level of 7.5 as a cutoff. And they have found that almost 1/3 of the patients have biochemical growth hormone deficiency. Although the pathophysiology was complex and was not fully elucidated, they have found that spontaneous GH secretion and GH response to provocative stimuli was reduced. Now, coming to the pathophysiology and the cause of this growth hormone deficiency in HIV patient, Initially they have postulated a fat-centric approach, a fat-centric etiology for the growth hormone deficiency, like HIV infection lead to the lipodystrophy, fat redistribution, and also the ART, which is used for the treatment of HIV infection, leads to fat redistribution. It leads to insulin resistance. The insulin resistance lead to hyperinsulinemia. It leads to reduce in the ghrelin secretion, increase free fatty acid. All these lead to increase the somatostatin tone and the reduced GS secretion. But all of the etiology of growth hormone deficiency in HIV patient could not be explained by only the fat-centric approach. So they have proposed that the multifactorial etiology, like apart from fat-centric approach, fat-centric approach for this for the etiology, HIV infection per se lead to the alteration in the immune system, the viral infection, poor health status, premature aging. All these will lead to state of chronic inflammation, and along with other pituitary dysfunction, it will lead to reduced growth hormone secretion. They have also evaluated the growth hormone response in HIV patient, compare it with the healthy control and those patients with hypopituitarism, and they have found that in patient with HIV infection, they have growth hormone secretion is less than healthy control, but it was somewhat better than those patients with hypopituitarism. They have also evaluated the growth hormone secretion in HIV infected patient compared with the obese patient, and they have found some similarity and few differences. The similarity was that the amplitude of growth hormone secretion was reduced in both patients with HIV infection and obesity, and the difference was that in HIV patient the frequency of secretion was maintained, and also the interval between the growth hormone peak growth hormone pulses was maintained in patient with HIV infection. Now coming to the bone metabolism, BMD was significantly reduced in HIV seropositive patient compared with the control, and in postmenopausal women, the prevalence of osteoporosis substantially higher in HIV patient. And it has been seen that there is lower marker of bone formation and increased bone resorption, and there is decreased level of 125 vitamin D, which leads to negative calcium balance and inhibition of bone formation. There are various etiology and pathogenesis which are not fully illustrated, but multiple factors are involved, and various T cells activation and expression of inflammatory markers like interferons, interleukins, which stimulate the osteoblast differentiation and resorption within the bone microenvironment. Apart from that, there are secondary effects of chronic infection such as weight loss, hypogonadism, and altered vitamin D metabolism. All these are responsible. And there is a prominence of established risk factor for bone demineralization among patients with HIV infection. Apart from that, there are independent effect of certain antiretroviral, mostly protease inhibitor is suggested. Now coming to the calcium and vitamin D metabolism, it was been seen that the HIV infected patients significantly decreased level of serum level of activated vitamin D compared to the control patient. And in few of the study, it has been found that these decreased production and action of vitamin D was the leading cause of hypocalcemia in almost 48% of the patients. TNF alpha was significantly higher, and it correlates negatively with this vitamin D level, and CD41 lymphocyte count was significantly lower in this patient, and also the serum level of ionized calcium and PTH was modestly but significantly decreased in this patient with low vitamin D, and there was significant increase in the serum phosphate level, but it was within the normal range. Now coming to the hypercalcemia, it was seen in around 29% of the patient with HIV/AIDS, and it is usually because of infectious granulomatous or neoplastic etiology. Hypercalcemia is also been reported in patients who were treated with foscarnet for CMV infection. And symptomatic hypocalcemia is uncommon in HIV patient, and it could be because of vitamin D deficiency or inappropriate PTH secretion or overt hypoparathyroidism or hypomagnesemia. PTH secretion is also significantly lower in patient with HIV infection than control, and it is impaired because of infection or neoplastic etiology. But the symptomatic hypoparathyroidism is can be seen as an initial presentation in patient with very high viral load. And parathyroid cell also express receptor which has a structural similarity with the CD4 molecule, which acts as a cellular receptor for HIV virus. And inappropriately low PTS secretion is seen in around 1/3 of the patient with hypocalcemia. Now, coming to the summary, I would say endocrine involvement is common in patients with HIV infection, and the etiology is multifactorial and still not clear. And adrenal gland involvement is the most common endocrine abnormality, and clinical examination and biochemical testing is very important, and the treatment of the hormonal abnormality along with the treatment of the primary disease is very important. Thank you.